Good day, everyone. Before we delve into our case presentation, allow us to take a moment to highlight the importance of recognizing early warning signs and understanding the broader impact of chronic diseases on a patient's overall health and quality of life. In this presentation, we aim not only to share the clinical details of a patient's condition, but also to emphasize the significance of holistic care, taking into account medical history, lifestyle, socioeconomic status, and the patient's access to healthcare. With that in mind, we now present the case of Mr. Teodoro de los Santos, a 53-year-old Filipino male whose journey through progressive shortness of breath and unmanaged chronic illnesses brings to light the challenges many patients face in our healthcare system.
So our patient profile, Teodoro de los Santos, 52-year-old, male, married, and a resident of Dumaguete City, Philippines. Nationality, Filipino.
The patient is experiencing shortness of breath.
Ano kakabatyagan mo, Mr. de los Santos, how?
Nang nabalay ako maginawa do.
The patient had no shortness of breath until 2 weeks ago. They first noticed difficulty breathing while climbing stairs. Over time, this progressed to shortness of breath even after walking short distances. Last night, the patient woke up gasping for air. They deny having fever, cough, hemoptysis or coughing of blood, chest, back pain, urinary issues, or swollen ankles.
And for the patient past medical history, we have hypertension for 10 years and type 2 diabetes mellitus diagnosed 2 years ago.
Let's begin by looking at the patient's social history. This part shows lifestyle factors that can significantly impact health outcomes, especially in chronic conditions. First, the patient smokes regularly, but the exact amount cannot be quantified. This is important to note because smoking contributes to cardiovascular and respiratory complications, which could worsen any underlying conditions. Second, the patient is currently unemployed. This social factor might limit access to healthcare, medications, or follow-ups, potentially contributing to poor management of existing illnesses like hypertension or diabetes. And lastly, the patient drinks alcohol regularly, again without a specific amount recorded. Alcohol use, especially when unmonitored, can affect liver function and interact with medications, which is crucial for us to consider.
Go.
The review of systems reveals that the patient has diminished breath sounds bilaterally with rales in the respiratory system. Cardiovascular examination shows tachycardia, a loud second heart sound, S2, presence of S3 and S4 gallops, and a hollow systolic murmur. There are no specific complaints reported in the renal system. The lower extremities shows no sign of edema. Neurological assessment reveals no deficit in the peripheral nervous system. Lastly, the gastrointestinal examination indicates a soft abdomen with no hepatosplenomegaly.
Now, let's move on to the physical examination findings of the patient. On general appearance, the patient appeared thin and looked older than stated age. For the vital signs, the patient had a blood pressure of 180/100 mmHg, pulse rate of 120 beats per minute, respiratory rate of 36 breaths per minute, and a temperature of 36.5 degrees Celsius. His skin examination revealed normal purpur with no rash, while lymph nodes were non-palpable. On HTENT exam, the sclera was anecteric and conjunctivae appeared pinkish. His chest and lung exam showed diminished ductal fermentus, dull percussion, and bilateral rales. In the neck, there were positive tubular engorgement. On cardiac exam, the heart showed tachycardia with presence of S3 and S4 gallops and a hollow systolic murmur. The abdomen was soft, non-tender, and showed no organomegaly. And lastly, the extremities had no edema and neurological findings were normal.
Now let's proceed to the patient's laboratory and diagnostic results which provide clinical support to our assessment. Under electrolytes, we can see that the sodium is low at 129 and the potassium is also low at 3. These imbalances may point to the fluid overload or medication effects. Looking at the renal function, the BUN is elevated at 30 and the glucose is at 258 mg per dl, which indicates poor glycemic control, likely linked to the patient's known diabetes. Urinalysis shows proteinuria and glucose in the urine, supporting kidney involvement and poorly managed diabetes. ECG findings show sinus tachycardia and left ventricular hypertrophy, which is consistent with the long-standing hypertension. Hematology values are within a reasonable range, although we should continue monitoring. For imaging, the chest X-ray is very telling. It shows an enlarged heart, curly V lines, and bilateral alveolar interstitial edema. These findings strongly point towards congestive heart failure, possibly due to hypertensive heart disease. Finally, arterial blood gases show mild alkalosis and hypoxemia, which could reflect compensatory mechanisms due to fluid buildup in the lungs.
The admitted diagnosis for a patient is congestive heart failure, likely secondary to hypertensive heart disease. This was identified as the primary diagnosis based on the clinical presentation and initial workup. In addition to congestive heart failure, we also considered several differential diagnoses, including chronic obstructive pulmonary disease, pneumonia, diabetic ketoacidosis. Upon further evaluation, we identified the following key problems contributing to the patient's overall clinical conditions. 1. Congestive heart failure. The primary issue requiring immediate management. Hypertension, a long-standing comorbidity and likely contributor to the development of congestive heart failure. Diabetes mellitus, which increases cardiovascular risk and may complicate treatment. Non-compliance with medications, which could have exacerbated all of the above conditions. And smoking and alcohol use, both of which negatively impact cardiovascular and pulmonary health. Now, I will be presenting the initial plan for Mr. De Los Santos' conditions. As a pharmacist, our focus is on optimizing therapy, improving adherence, and supporting patient education. For congestive heart failure, the patient presents with signs of fluid overload. We recommend initiating diuretics such as furosemide to manage fluid retention. Beta blockers and ACE inhibitors are also important to improve cardiac function and reduce mortality. We will monitor oxygen saturation levels and provide supplemental oxygen as needed. Next is for hypertension. The patient also has elevated blood pressure. We will initiate or adjust antihypertensive medications to reach target beta levels. Additionally, we will encourage lifestyle modifications including sodium restrictions, regular physical activity, and smoking cessation. In diabetes mellitus, in order to manage blood glucose, we will adjust insulin or oral hypoglycemic agents depending on the patient's current levels. Patient education and diet, exercise, and regular blood glucose monitoring is crucial to ensure glycemic control. For non-compliance with medications, the patient has shown signs of non-adherence. We will provide comprehensive medication counseling to identify and address barriers. If necessary, we will refer the patient to a social worker for additional support, especially if financial issues are contributing to non-compliance. And lastly, smoking and alcohol use. As these lifestyle factors can worsen the patient's condition, smoking cessation counseling will be provided along with pharmacologic options like nicotine patches or bupropion. We'll also counsel the patient to reduce alcohol intake, which can impact both